Hamınızı bir də salamlayıram. Nahar fasiləsindən sonra biraz konsentrasiya olunmaq və məlumatı tam qəbul etmək sözsüz ki, çətinləşir. Amma mövzunun aktuallığı və verilən materialın verilmə forması mən düşünürəm ki, sizdə o beyinlə mədə arasında olan mübarizənin beynin hesabına qalib gəlməsinə nail olacaq, səbəb olacaq. Mövzu nəyə görə maraqlıdır? İndividuallaşdırılmış sırf elə bilin ki, bizim konfransın, bizim bugünkü yığışmamızın əsas mövzusu İndividuallaşdırılmış Funksional Stomatologiya. Daniele Togni öz məruzəsində nəyə toxunacaq əsas? Sübütlara, dəlillərə əsaslanan səhiyyə təbabətlə individuallaşdırılmış, fərdi yanaşılan təbiət arasında, səhiyyə arasında fərqi göstərməyə çalışacaq və ümumi tibbdə, ümumi təbabətdə bir çox ağır xəstəliklərin, ürək-qan damar xəstəliklərin, xərçəng kimi ağır xəstəliklərin individual yanaşma hesabına daha uğurlu nəticəsinin, müalicəsinin daha uğurlu nəticəsinin alınmasına görə həmin yanaşmanın stomatologiya müxtəlif sahələrində, stomatologiyada komanda şəklində yanaşmaya tətbiq eləmək olarmı? Əgər olunsa, bu nə qədər uğurlu olacaq? O mövzu ətrafında öz fikirlərini sizlə bölüşəcək. Uğurlar.
Thank you, Teymur. I didn't understand what you said, so I hope you didn't tell bad words about me.
No, nothing.
Okay. Anyway, I want to start to thank a lot, Teymur. Really, you did a great job. No, I have really, because what's amazing. This is the first time for me to be here, and I never could imagine that was so nice. Your organization with your EFO team was amazing. Okay, so thank you very much. May I have my presentation on the screen, please? Okay. So my task today is to talk about individualized functional dentistry. So to explain a little bit what is this concept. Basically, in medicine, we can outline two approaches to the patient in prevention, diagnosis, and therapy. The evidence-based medicine and the individualized medicine. In the past, these two approaches seem to be opposite, but currently, in scientific literature, you can notice an awareness that they have to be somehow reconciled. The starting point of my interest for individualized medicine was a course about sleep apnea, and especially the part about the algorithm to choose the therapy approach to the OSA. The classic therapeutic approach of the obstructive sleep apnea was based, and still is often based, on the AHI index, that is the apnea-hypopnea index, that is a good epidemiological index to describe risk groups. For years, the clinician chose the therapy based on this index. But in the last years, the pathology was showing its complexity, not only from the pathogenetic point of view, but also from the clinical point of view. For these reasons, it was necessary to completely reconsider the clinical approach to the patient affected by mild and moderate forms of OSA in the light of concomitant pathologies, other risk factors for the individual patient, including family and genetics. Nowadays, we know that the AHI index is not always a representative information of the overall severity of the patient situation. If you look at the table in this slide, it is clear that the risk profile of the patient number 1 is far lower than the patient number 2, even if the AHI index tells us the opposite. According to precision medicine approach, this is the therapeutic workflow for sleep apnea, and you can easily understand what a more articulated assessment of the risk profile of the individual patient is. and how much more effective support we have as clinicians for the treatment choices and the consequent wider success rate. Each individual patient will have the appropriate treatment according to his differential diagnosis and risk profile. And you see here, at the bottom of the page, the different kind of sleep apnea. Now we can start to do a basic comparison between evidence-based medicine and precision medicine therapeutic approach. Evidence-based medicine works well when the disease is a simple one from the pathogenetic and clinical point of view. In this case, the chosen index is truly representative of the risk profile of the patient, and evidence-based medicine is of valid support in therapeutic choices. On the other side, precision medicine, or individualized medicine, makes a more comprehensive and precise assessment of the risk profile of the individual patient, require a broader cultural knowledge, but is much more effective in supporting the treatment choices when there is a complex disorder. So it's time for definition. This is the definition of evidence-based medicine approach by Professor Sackett, that was the father of evidence-based medicine, in one of his papers. Evidence-based medicine means integration of clinical expertise with the best available evidence that you can find in the literature to design the treatment plan for the individual patient. Here you see more in detail what is the original definition of evidence-based medicine. Best available external evidence means clinically relevant researches, especially from patient-focused studies like randomized clinical trials on large sample, but about the accuracy of diagnostic tests, the power of prognostic markers, and the efficacy and the safety of therapeutic regimes. More, the individual clinical expertise means the proficiency and the judgment that clinicians acquire through their clinical practice and experience. This is the original triad of evidence-based medicine. We have to put together patient, request, and expectation. You have a patient to treat, which is request, values, environment, and expectation. You have to know the patient and share your clinical decision with him. Clinical expertise means that the doctor has to use his experience and knowledge because it is as relevant as the external evidence for the treatment of the patient. Research's evidence has to be integrated with the clinical experience. So external evidences in literature, but not only, have to be integrated when there are clinical relevant statistical index. Evidence-based medicine is not a cookbook, because ideally it requires an approach that integrates the best external evidence with individual clinical expertise and patient choice. External clinical evidence can inform, but can never replace individual clinical expertise. And it is the expert, the doctor, that decide whether the external evidence applies to the individual patient or not. At least this was the Sackett vision in 1996. But some critical issues of evidence-based medicine are more and more evident as the progressive in genetics or genomics and biology are increasing. Now we know that in many diseases like OSA, cancer, diabetes, cardiovascular disease, there are great differences among individual patients in risk factors, disease course, and the response to therapy. Scientific evidence is produced by strict evidence-based medicine approach with randomized clinical trial studies rarely provide relevant knowledge that is helpful for a good quality in diagnosis and treatment of the individual patient in everyday practice. This knowledge is formalized in guideline and rule-based reasoning that are not able to support complex clinical decision-making. There is also the risk that the doctor just apply the guidelines by evading the responsibility and the difficulty of interacting with the individual patient. Rule-based reasoning and the use of general guidelines as imposed by evidence-based medicine does not accommodate the complex reasoning of doctors in clinical decision-making. In this article that you see here, some critical points about the importance of randomized clinical trials are pointed out. Randomized clinical trials are not patient-centered. They are performed on homogeneous patients groups, artificially selected by banning many patients through the inclusion-exclusion criteria. The evidences are taped from researches on population, and there is an intrinsic gap between population-based researches and its application to individual patients. For these reasons, the evidences coming from studies based on statistics that are at the end consider an average treatment for an average patient often fail to support clinicians in their practice with individual patients that are outliers. And also, we have to ask ourselves, are randomized clinical trials the only methodology for producing scientific evidences? This is not true. Worrell wrote that the epistemic power of randomization is continuously overestimated. Non-randomized studies can also be good. Case-based medicine can provide evidences. Narrative medicine and creative thinking have their right to have a place in the epistemological process. Evidence-based medicine claims to support an objective, a scientific rule-based reasoning, and the idea of hierarchy of evidence that prefer standardized trial over professional judgment. We assume that the desire of medicine to work scientifically derives from the confidence people have in scientific objectivity and rationality. For this reason, we use the concept of scientific, implying that the quality of knowledge is warranted, but is not. Being scientific in the narrow sense cannot warrant this quality. The dichotomy between objective science and personal, means subjective, judgment is false. All rational reasoning involves human subjects and situated in a local context and then is inherently subjective. Evidence-based medicine fails to acknowledge that gathering, interpretation, and application of evidences requires anyway human subjects making judgments. This article helps in understanding the differences between evidence-based medicine and precision medicine with a clear example. For many therapies, individual patient response depart widely from the average treatment effects. In the picture, you see the red line that is the average percentage of survival predicted after surgery of esophageal adenocarcinoma. If you compare the individual patient's specific predicted survival, so the gray lines, you understand immediately that the differences in terms of years are relevant. Look at the patient number 1, the orange. The survival rate is 78. And now look at the patient in green, the number 2. Patient survival is 2%. And the average is 30%. So there is a huge difference between the average and the individual patient survival rate. Most medical treatment guidelines are designed for the average patient as one-size-fits-all approach, which may be successful for some patients but not for others. Precision medicine known also as individualized medicine, is an innovative approach to tailoring disease prevention and treatment that takes into account differences in people feature, genes, environments, and lifestyle. Precision medicine means the right treatment for the right patient at the right time. Advances in precision medicine have already led to new discoveries of powerful treatment that are tailored to specific characteristics of individual, such as patient genetic makeup or genetic profile of an individual cancer. Going back to dentistry, this is the list of the individual parameters in dentistry that can be different in each patient. Can you imagine the number of variable combinations that these 28 factors could produce? Do you think that an average treatment for an average patient, for example in TMD, will be often successful? We should also point out that TMD is a term that includes different pathology. This means that the term is too generic from the clinical and research point of view. In this article that we read during the VieSID scientific literature group, Saratti et al. Highlight that there is a lack of consensus about the method of functional assessment of the stomatognatic system. They write that in modern dentistry, it's futile to treat patients using a mechanistic, sectorial approach that misrepresents patient behavior and request, because the task should be to conserve healthy teeth for much longer without risking overall health. According to the authors, the key point to reach this goal is to encourage personalized medicine and interprofessional collaboration in clinical reality by a large use of dynamic methods of assessing oral function. I must say that words like individual assessment, functional evaluation, and interdisciplinary collaboration are quite familiar for the member of the VieSID school. Now, in this scenario, the question we should answer today are, it is useful to perform individualized dentistry. When? How can we perform an individualized dentistry? This interesting article by Corman and Duff, published on the Journal of Dental Research in July 2012, is helpful to understand better the situation. The approach of personalized medicine or dentistry pass through a stratification of the patient and then through an evaluation of the differences among patients. This means genetics, biomarkers, individual features, to create subgroups. In the field of oncology, they started earlier to work with precision medicine approach, and now we know that as the cost increases to implement precision medicine, we have to involve in this direction all the other stakeholders to be successful. The goal is not only to improve treatment results with tailored intervention, but also to improve prevention of diseases. Precision medicine approach is much more effective in treatment of complex disorder. In dentistry, which are the diseases that can take advantage of precision dentistry approach? According to the authors, chronic facial pain, rampant caries, and severe periodontitis. Chronic facial pain is often related to temporomandibular joint disorder. According to the authors, these two criteria are the reason why a precision dentistry approach can be an advantage in treating TMD. The complexity of TMD with the lack of conclusive studies about therapy and then uncertain treatment results, and high impact consequence of inappropriate treatment of this disease. With precision dentistry, we could stratify our patient and identify individual patients that benefit from specific therapy. What is the attitude of our school towards individualized dentistry? we must consider that each patient has individual characteristics that make him unique. Average and regression to mean are function of research and statistical analysis, but can be totally inappropriate for our patient in everyday practice. If you look this variation, Kristian already was showing this slide. This is the sagittal condylar inclination in 300 patients. You realize that there is a wide variation among individual patients. For this reason, assuming an average condylar inclination in diagnosing and treatment of patient is a huge mistake. The individualization of the diagnosis and treatment plan is mandatory. The large range of variation in condylar tract, inclination, and bended angle in this study demonstrate that in clinical examination, as well in prosthetic reconstruction, more attention must be paid to individual circumstances of the patient. This is an overview of the information about the individual patient that, according to our VieSID standard, we collect for each patient in a systematic way. So general anamnesis and dental anamnesis, analysis of the face of the patient, infraoral picture, so all the individual feature. Anastasia, after me, will explain better in the clinical reality what does it mean. In this slide, you see more in detail the first step of the systematics, individualized diagnostic collection of findings. As Kristian said, at that time we were doing everything in an analog way, but now you can do everything in a digital way through the Gamma browser. And here are the next steps. So this means the clinical instrumental analysis and the instrumental analysis in the articulator. And the last steps are the part related to the X-ray and the CEF and the MRI when there is a need. To summarize, in VieSID school, we have the goal to teach the respect of the individuality of the patient during the diagnostic process and in designing the treatment plan. We want that our students develop a holistic view of the individual patient with an interdisciplinary and multidisciplinary approach that focus on occlusion and function. For this reason, the concept of individualized functional dentistry is the best way to have more success in therapy and dysfunctional patients. And now I want to show a case just to let you understand better in the practical environment, how does it work. So this is a lady, 79 years old. It's not a recent case. It's, let's say, an old case, a case that I did some years ago. But the idea is that these kind of cases treated in this way should be stable for a long time. And stability for a long time is also a key point of our success. All the cases are successful in 1 year, in 1 week, in a short term. But let us go through the follow-up. The follow-up is the truth of our result. So those were the picture of the face and the mouth. It's not a dysfunctional case, it's a standard case because this approach works very well also in the normal cases. Of course, it works better. We have more ability to have a success if we are treating dysfunctional patients. So this is the anamnesis, the muscle palpation, the analysis of the chronic pain. Of course, we mount the cast in the articulator. At that time, we were using the analog articulator, but you can do the same with some, let's say, attention when you do it in the digital environment. This is the analysis of the X-ray, and of course, we did the cephalometric tracing according to Slavicek and according to Sato, because also these give us a lot of individual information about the skeletal pattern of the patient. We did the condylographic tracing in that patient, because these are useful for the dysfunctional patient to decide the therapeutic position, but in a patient without dysfunction, it's also useful to program the articulator. And at that time, the digital environment that we have nowadays was not available. So what we did, we were digitizing the cast. We were able to transfer the cast in a CAD system that was not the system that we have nowadays. It was many years ago. And we superimposed, these are the condylographic tracing, okay, of the protrusion. That is the hinge axis, because the concept of the hinge axis is a key point for us. And with this information, we are able to analyze, first of all, the movement of the patient. Then we did the analysis of the cast, of the upper cast in the digital environments, analyzing the medial-sagittal plane and the other planes according to the bony ridges. This is the digital static analysis, of course, again, performed in another CAD software, because at that time the Gamma software was not available. Nowadays, in the Gamma browser, these steps are very easy, very quick, and give you a lot of information. And then we were analyzing the active centric arch, the passive centric arch, the inclination of the guidelines. And for this patient, we realized that the posterior teeth of the upper prosthesis were on the ridge, but the protrusive guidance was not correct. And you have seen at the beginning what was the result of that problem. In the same way, we were able to analyze the Spear curve on the right and on the left, and the occlusal plane right and left that you see there. And you see that also the occlusal plane were not correct for that patient. At that time, we used the VTO in this way, and for the cephalometric point of view, we were focused on the lower facial height that for that patient was correct, was in the green area, so was in the average position. We didn't want to change that. But then we started to design the new lower prosthesis reconstruction in the digital environment. And this is the virtual alignment and setup of the lower canine and incisor, so the anterior part. So you see there the canine, and then step by step the lower incisor. And then we did the digital design of the new occlusal planes, right and left. Okay? And you see the change. The white area is the new design. The green one was the old prosthesis. Then we did a correct alignment according to the Spear curve, right and left. And this was the final result. You see that we have the active centric, the cusp on the lingual part, and this is the design that we wanted to reach. This was the static part. At this point, we started to program the dynamic part. So we introduced the information coming from the condylography. This is the protrusion. So the yellow one is the starting point. The blue one, the light blue one, is the ending point. And with this movement, we were able to decide which was the correct inclination of the upper guidance. Okay? And in the similar way, we did the program, the design of the lateral obtrusive guidance on the canine. At that time, we were not able to perform also the prosthetic reconstruction in the digital environment. Was too difficult at that time. So we transfer all the information in the analog articulator, and this was the result of the prosthetic reconstruction. This is the setting, the individual setting of the articulator. This is the design in wax and the final prosthetic reconstruction according to the inclination of the guidance, according to the position of the teeth, the passive centric, and so on. And this in articulator, this is the result of the final reconstruction. Of course, everything was transferred, and this is the result in the mouth of the patient. Okay, the dental arches before and after. The patient, the smile of the patient before and after. This was a normal patient without these functional problems. This is the follow-up in 2015. So you see that there are no big problems. The patient is not a champion in cleaning the teeth, but everything is rather stable. The overjet and the overbite, the occlusal surfaces, the movement, so protrusion, lateral protrusion, right and left. You see the disocclusion in the posterior area. And this is the follow-up in 2017. I saw again the patient. You see that there are some teeth in the upper jaw that are a little bit worn out, but this is normal because the patient is using the teeth every day. She likes to eat crunchy bread, so the wear of the upper teeth is normal. We can replace it and reproduce the similar situation in the ear. And I saw again this patient in 2023. She was falling and she was breaking the two lower incisor here and here, okay? But was not a big problem because after the healing process, we were able to put 2 implants and we put again 2 teeth. So the patient is still with this design of the occlusion now. And of course, she is getting older, but this is life. And this is the reason why I like to call this individual functional dentistry in occlusion medicine so successful and helpful for us to treat the individual patient. Okay, that's it. I hope you enjoyed this, and you will understand more when Anastasia will explain the functional analysis.
Sertifikatı təqdim etmək üçün Həkimlərin Təkmilləşmə İnstitutunun Ortodontiya Kafedrasının müdürü, tibb elmlər doktoru Zibə xanımı.
Thank you very much for a very interesting lecture. Thank you. Mən öz adımdan və Həkimlərin Təkmilləşmə İnstitutunun Ortodontiya Kafedrası adından təşkilatçı quruma, Doktor Teymura böyük minnətdarlığımı bildirmək istəyirəm ki, belə maraqlı konfrans təşkil eləmişiz. Sizə gələcəkdə uğurlar arzulayıram və bütün gələn qonaqlara da minnətdarlığımı bildirirəm ki, bazar günü öz vaxtını bura sərf ediblər və yeni biliklər üçün bura gəliblər. Çox sağ olun.
Daniele, just a second, take a picture.
Okay. Thank you.
Növbətə çıxış üçün söz verilir Tribula Çemləşqa Joannaya. Gamma browser və Exagat proqramlarında rəqəmsal iş prosesi və ardıcıl print-up fəndlər, məsləhətlər və tələblər. Qeyd edək ki, məruzəçimiz diş texnikidir və 98-ci ildən bura diyezli və katkan proqramları üzərində işləyib. 250-dən çox full reabilitasiyalarda texniki hissəni işləyib hazırlamışdır və onun da çox maraqlı bir məruzəsi var.
Bəli, mövzu çox maraqlıdır. Mən düşünürəm ki, auditoriyada diş texnikləri də var. Diş texnikləri üçün də bu mövzu çox maraqlı olacaq. Mən düşünürəm ki, diş texnikləri üçün maraqlı olan, həkimlər üçün maraqlı olmayan, həkimlər üçün maraqlı olan, diş texnikləri üçün maraqlı olmayan mövzular yoxdur. Yəni, hər iki qrup üçün eyni mövzu, eyni dərəcədə maraqlı olmalıdır. Bu çox vacibdir. Bizim məruzəçimiz özü Polşadandır və məruzəçimiz çox maraqlı mövzuya toxunacaq. İndiki dövrdə zamanın tələbi rəqəmsal stomatologiyadır. Xanımın vuruladığı məsələ rəqəmsal stomatologiya keçmək üçün və rəqəmsal stomatologiyada doğrudan uğurlu olmaq üçün analog stomatoloji bilikləri, əgər belə demək olarsa, həmin biliklərə yiyələnmək lazım deyil, vacib deyil. Eyni zamanda da sözsüz ki, yenə də həmişə biz ölçü materiallardan istifadə edirik, orada xətalar var. Və inanın ki, nə qədər bizə firmalarda, nə qədər rahat olsa da, rəqəmsal stomatologiyanın üstünlüyünü göstərsələr də, həmin öz məruzəsində xanım texnik, digital stomatologiya, rəqəmsal stomatologiyanın da çoxlu xətaları olacağını və həmin xətalara hazır olacağımız haqqında bizi məlumatlandırmaq istəyir.
Do you hear me?
Yeah, now we can hear you.
Okay, great. I only switch on my speakers.
Okay, good. Have a look.
Okay. I think now will be better. So let's maybe start. First of all, I want to thank all community of VieSID for trust and possibility to present here this presentation and share my experience. Here in Baku. Thank you, Dr. Timur Maladov and his team for invitation and organization this wonderful event. Kristian, thank you for your support. And for me, Baku personally is an important place because my husband's great-grandfather came from this city. So, hello, Baku. On the beginning, I would like a little bit introduce myself. I came from the north part of Poland, from the seaside. We work together with Jack, my husband, in Sopot. It's a nice touristic kurort city. And we live on countryside in small village Drewnica. It's not so far from our laboratory in Sopot. And as you can see, it's somewhere in the middle of nothing, 4 kilometers from the seaside. So we try to combine two different worlds. I see that the connection is not so fast, so sorry for the, not all movie will be, I think, great. My professional development started 27 years ago. It's quite a long time ago. I started practice at 96. It's my father's laboratory. In 2030, I finished the VieSID education in Vienna. In 2017, I became a VieSID teacher for dental technician. And the same year, we opened our training center, School of Smiles. And in 2019, I became not-occlusal compass international trainer. In my daily work, apart from running the laboratory, I plan occlusal restorations, make wax-ups, accept digital design and layering ceramics on aesthetic cases. From time to time, I have individual appointments with patients to discuss the aesthetic of the new smile and make photos for smile design or facial registration. Once a month, I give courses in School of Smiles. We have maximum 12 places for students. Our school is located also on countryside in Old Barn, and we organize from basic courses like models, themes to more advanced not-occlusal compass, biofunction, and the cherry on the cake is the VieSID curriculum for dental technician. But my work was not only about the teeth. In work, we must keep balance, and the best balance we found in the nature. So after pandemic, we start to be farmers, growing old grain, hemp, and lavender. And we run a farm, prepare various ecological products from what we grow. I started learning herbal medicine and making natural cosmetics. Close contact with nature recharges our internal batteries and gives us even more satisfaction from working as a dental technician. And everything is connected in harmony and in balance. And as a result of these activities, we connected our two worlds and create a patent for the production of homeopathic splints from resin containing CBD hemp extract, which we produce ourselves. Several studies has been already published on the beneficial effects of the hemp extract with TMG muscle relaxation, reducing tension and pain. But back to the topic today, I will share with you my experience in digital dental technology. I have been working this way for 19 years, combined with today. On the beginning, it was this technology was a little bit limited and not perfect ready, but for that time it's give for dental technician big jump to the future. It starts from Procera scanner, first CAD/CAM design chrome produced from alumina oxide in Sweden, based on virtual design which we make in laboratory and send via software. Then was first CAD/CAM zircon SAM. Its change method of preparing final reconstruction gives us better precision, possibility to easily repeat part of cases, selection of different new materials. Sorry. Then to the market and dental offices came intraoral scanners. Now we know advantage and disadvantage of this tool, and from which cases it's worked good and for which not yet. Sorry. Always company and sales manager offering to us the best solutions as a magical wand. But the real development starts when we as a dental technician and dentist start to work and make lots of mistakes that show an imperfection on the software system or devices, but it is always an impact on development and changes. Then jaw tracking devices. We have different possibilities on the market. As Kristian mentioned, we should choose very carefully. Depends on our needs and knowledge, because it is still only device. It's not make for us decision how to help the patient. We should know for what reason we want to use it, and we need to know how interpret lots of data from these devices, know how to compare them and what concepts stay behind them. Companies sell us a vision of safe, fast, easy, accurate, and cheaper work. Is this really the case? How it looks like from my perspective as a dental technician and technician who has been working for 11 years with the VieSID concept, which I can say is the most demanding and accurate concept. I would like to share my experience with new Gamma digital workflow and connection with ExoCAD, which is my daily system. I don't will be talking a lot about deep analysis of this case. I focus on technician part of workflow, preparation full mouth wax up, which we can name cleaning up according to chondrography data and step-by-step procedure. VieSID concept, apart from extensive diagnostic and diagnosis accuracy, focus on precision and working on individual chondrography data. This concerns the precision of the beginning, from the precision of models, articulation. Of course, we need to make all measurements and calculation. After that, we start planning our new occlusal plane in new vertical dimension and try to achieve best occlusal surface with great morphology, maintaining contact points in occlusion at the level of 8 microns posterior area and 16 microns anterior area. We keep sequential guidance, proper contact points to prepare safe rehabilitation and gives to the patient best chewing efficiency without interference. We can't forget about aesthetics. The goal is the repeatability of what we technically do in the articulator and what we obtain in the mouth. And we already know how to achieve this in the analog way, keeping precision at the level 8 microns. And how can we handle this now in the digital way? On which steps we must be careful? We know that the most important is to transfer accurate real hinge axis from the patient to our workspace, the same as in analog way. Today, Kristian also say about this topic. Axis is the first small movement, rotation of the mandibula, and we need to define hinge of this axis. This hinge is not anatomic hinge of condyle, but kinematic, dynamic hinge of rotation, connecting both condyle in one movement of rotation. Transferring this individual axis of rotation to the working space guarantees the repeatability of contact points in occlusion between the articulator, analog or virtual, and situation in the patient's mouth. It will protect us against unnecessary work equilibration in the mouth and changing the position of the jaw and joints in uncontrolled directions. Today, only Gamma Dental gives us opportunity to switch this important individual hinge to virtual space very precise. So we can match the real position of the models in virtual articulator, the same like in the patient's skin. Other jaw tracking system transferring only arbitrary anatomic position of the axis, or even this is not important for them. In digital workflow, we switch between plaster model to intraocular scan, from bite register on RP plate or silicon to scan bite, from analog articulator to virtual, and from waxing to cut design and printing. And for the last, check our work as a mock-up. We expect the same result and precision as in analog way working. This is our wish. We start as a regular digital way to prepare scans, upper and lower, and scan of bite. ICP, intercast position, RP, reference position, therapeutic position with reposition. It depends on the case, what we have and what we need. We can use RP plate for scanning, we can use jig, we can scan with splint, which we needed a little open for better scanning. Then next step, regular VieSID workflow, finding our axis, making condylography, and switch to aluminum transfer as in analog way. And on this step, normally we articulate upper cast model, but in this situation we don't have it because we have only scans when we work in digital workflow. So we use new transfer block, this gray plate with marks, which we need to scan to transfer this bite fork position to virtual space. And this position is fixed with our axis. Then in software Gamma, we superimpose all scans together. Scan upper jaw and lower together is mounting in the scanner software. So we import them to the Gamma software in random position, and we only need to positioning them using this additional scan of the transfer block and bite fork. In software, we choose one of three this transfer block, the same which we mounting during scanning, and superimpose position of our scan of transfer block to position in software. Then we match scans of upper arch to the fork, which is combining together with transfer block, and block define our position in virtual articulator in proper axis. Simply superimpose by selecting the same point on two scans. Now our scans upper and lower together with scan of transfer block are matched to each other. In virtual articulator in the same position as in patient's mouth, or maybe say in school. And in proper individual precise hinge axis. Our virtual model must be segmented in Gamma software to all diagnostic measurements and occlusal plane calculation. During this segmentation, we put all necessary information as where is each cusp of each teeth, where is fossa, where is incisal edge, where is medial distal ridge, and this coordinate allow you to make accurate measurements of current chewing efficiency and in digital way, the same as we make diagnostic occlusal protocol in analog way, but a little bit faster. We need to choose the vertical height for our rehabilitation. Our calculations are based not only on aesthetic point of view, but most on cephalometric calculation and skeletal class of the patient. Of course, Gamma software makes this for us not so complicated and calculate count of distance from apical base of maxilla and mandibula, and we have norm in degree in which we should stay. And software give us also information how much in millimeter on articulator pin we should open or cross vertical high dimension. It is possible because all part of gamma system like software, condylography, cephalometry, virtual and analog articulator are calibrated in the same coordinate in space. But let's focus on what we as a dental technician need to complete our project in digital way. On the first step, we need export to ExoCAD position of our scans related to articulator with proper hinge axis and relation upper scan to lower scan. Second, we need vertical height of dimension, which is needed to rehabilitation. And third, we need our new occlusal plane count. In this step, I don't export sequence of movement, the sequential movement and individual patient movement, because this sequence in software is defined by lower tips of cusp. Now it will be defined by our old tips, which are old active centric lower arch, and we need to change this anatomy. So this sequence of movement we will do in next step to program virtual articulator. So we have to export from gamma to ExoCAD on first step. Position of the scan oriented in articulator to the hinge axis, the individual proper precise hinge. Upper and lower in relation and height to rehabilitation, and our new proper occlusal plane. Now it's time to combine analog knowledge from sequential wax-up planning with digital tools. We need to know what is active and passive centric of lower and upper arch. We have we have contact point in occlusion and why we should have it in these specific places. How achieve natural nice morphology of teeth in different stiffness of cusps, where we have guidance and how achieve sequential guidance, how we measure occlusal plane, which points define lower functional occlusal plane, where and how prepare retrosive stop and barriera on teeth to protect joint. This is very important part of planning. All this knowledge help us to provide in proper way digital tools, software, and control them. Of course, to prepare these steps properly, we need to look at our condylography data to know a little our patient. What SCI, sagittal condyle inclination, we have, how long movement patient is using during speech. We can check it on speech chart. This helps us choose the length of movement. Check which skeletal class to choose compensate mechanism which we should to use. What occlusal plane we have from the start to check calculation of new occlusal plane and cusp inclination. We need to remember about SPI and Wilson curve, and on this step also to define position of lower incisor, so we need to control aesthetics. During the diagnostic calculation, which are a part of preparation to planning in analog and digital way, we notice that the patient have also problem with chewing efficiency. The parameter of DOA, angle of disclusion, is too high. And this will be our goal to change it in prosthetic way, to support good stabilization and give for patient best chewing comfort. We need to know what to do, not only export data from gamma to ExoCAD. Functional geometry in VieSID concept help us understand that topic. Functional geometry give us safe ranges to play with. Sagittal condyle inclination we get from the patient. We should keep occlusal plane, OP, between 0 and 15 degrees, depends on skeletal class. Cusp inclination between 25 to 35 degrees, and angle of disclusion between 8 to 30 to stay safe. Less than 8 microns provide interference during dynamic movement because surface of cusp are moving too close during chewing. More than 13 degrees, we lost chewing efficiency because surface of cusp are too far from each other and patient cannot crush food properly. In functional geometry, we use the formula. STI is sagittal condyle inclination, it is anatomy of the patient. It's equal to SI, cusp inclination. We can change it in prosthetic way, plus OP, occlusal plane. We can work on it. changing the count, and plus DOA, angle of disclusion, we should keep it on norm. In this patient, we have to change occlusal plane to make them more steep for this STI in the left and right side, and make anatomy of the new teeth more like 30-35 degree. It will be challenging because we don't have a lot of space to open. Our lower facial height is up to the limit. Now in ExoCAD, we want to design new proper active lower arch, and we are thinking about a passive one also. Create new anatomy of lower arch, lower teeth. We need to start from lower incisor because it is the first point where we put our new occlusal plane to measure the count. So we have some rules. Page principle, which states that the lower incisor are tised perpendicular to the radius of the jaw closing pad in class 1, skeletal class 1. In class 2, we have less than 90 degree, and class 3, we have more than 90 degree. So we have also rules for overjet and overbite. Overbite 3.5 to 4 millimeter, and overjet 3 millimeter will be perfect. We should leave free functional space. And also from aesthetic point of view, golden ratio for lower incisor can help us choose the position and length lower incisor. On this step, we should also thinking about aesthetic of uppers. During defining position of lower incisor, where they touch upper teeth, where we should have upper incisors from aesthetic point of view, and we have some rules for that too, which can help us. Incisal edge of upper incisor should gently touch lower lip and follow the shape of lower lip during smile. In the rest position, we should see about 3.4 millimeter of upper incisor when the patient is woman, or 1.9 millimeter when the patient is man. After choosing position for lower incisor, we use the visualized new occlusal plane to find the position of the distal cast of lower 6. These 2 points give us good count of functional lower occlusal plane. And then we put the rest of the teeth from the lower arch. We can choose from library first with proper stiffness. We can choose from different libraries and shapes as we like. And on the next steps, we must individually adjust the anatomy of these teeth to later obtain the correct contact points in proper places. Control with curve of speed to create nice and harmonic active centric arch, and prepare good morphology of lower premolar to have possibility later to create good retrusive stop and control. And then we go back to gamma with our new lower arch, new lower active centric arch. This is the point where we start to create our individual jaw movement sequential guidance. In Gamma software, we import this file from ExoCAD as a STL file, our new lower arch. On this step, we match our new model with old one. Don't change the position, don't change the vertical dimension. We only put new model with new teeth. We segmented model again, and now our Gamma software knows where is a new tip of the teeth, new anatomy of the teeth, and this is time to define sequential guidance according to condylography. We can choose sequential movement for articulator setting or direct movement from condylography data. On this step, we export this movement as a jaw motion to ExoCAD back to finish our upper arch, and we need to export each sequence of guidance separately. So guidance for the 6, for 5, 4, and last 3 and anteriors. After export sequential movement from Gamma to ExoCAD as a jaw motion, we create our new upper active centric and passive centric in maxilla. We need to remember about proper teeth morphology. Of course, proper occlusal surface and occlusal compass. There is also new plug for exocut, which can help us remember about the direction in occlusal compass. When we have in exocut this jaw motion or sequential movement, the tip of the lower cusp will be guided on surface on upper teeth according individual way and stiffness of moving. This is our basic contact points in occlusion, the precise contact point which we want to achieve, and our new morphology of upper arch with new proper contact points. And the crista transversa, very important part of upper six, the shape, the stiffness, and the contact in static, we should keep in the proper places. And on the end, we create our guiding way from point F1 to F2 in sequence from 6 to the front. Exactly the same way as we do it in analog way, only two we have different. And rest anatomy of the teeth, we check over jet, over bite, we check harmony, we check aesthetic with the photography before we go back to gamma. Exporting STL5 from exocut, new upper, new lower, and we check everything again in the same way like we make digital occlusal protocol, checking contact points, guidance, and disclusion, checking if there is no mesiotrusion, disturbing lateral occlusion, interferences, everything is okay. And what will be our next step? How to make try-in of our beautiful functional project. How to check if it is real functional, good contact points without interferences, good aesthetic for our patient. The patient is living in real world, not in digital. And like Professor Slavicek say, the key point of any treatment must be a valid diagnosis. It is the only point to initiate a casual therapy. So our new wax up or print up work plan based on diagnosis must be verified before the final therapy begins. So to we need to print our models. We must use special model to create printed model. It will be good if we have possibility to create lower model as a master model with separate teeth. Then we have possibility to check in reality our sequence of guidance. So it not will be so fast way of working. Check it in occlusion. That means that we need to articulate our printed models. So to have precise articulation, you can check this articulation. We need to prepare double split cast before our printed, based on our printed models, and articulate them in the same position in real articulator. So that means that we need to create reverse transfer to put our printed model in the same relation to the real articulator as it was in virtual. Then we can check there is no interference, check sequence of guidance and contact point in occlusion. Are they in the same place as we planned in our computer? We prepare our transfer base, we digitalize it and prepare something like byte between our upper model, upper STL5 model and lower transfer plate. We print this byte and articulate with printed upper model in a regular way. Now we have our printed model in real articulator in the same position as in gamma and exocut. And next step is add to this lower model, and then we can check our occlusion and guidance. First, we checking occlusal point in articulator in a medium settings, and then we program our articulator and check in dynamic. These are our contact point in digital plan, and on printed model, I think we are quite close to contact points from digital design. Then we can check sequential guidance. Is they on proper stiffness? We check it with color foil between teeth and between pin in articulator, checking there is no interference. We are sure that we get proper canine guidance and anterior guidance on incisal and canine. We also check the rest sequence in guidance the same way as analog way. That's why we need to separate teeth removing from the our model. After we finish, we are sure that our new plan, print up for rehabilitation, this patient will be working in the patient's mouth properly. And then we are ready to make our silicone index for mock-up. We can use different type of index and silicone depending on our needs and sense of aesthetic. One silicone is more clear but soft, other little bit harder but not so clear, more bluish. So it depends as we wish. After try-in, we can continue in a regular way this case. So that's mean this day digital. But if we start talking about printing model, because this is only this way we can check our plan. We must know what affects to the precision of models. Are they repeatability? Can we print from one scan always the same model? Do we need to check it? Are they stable during time? Is it faster and cheaper way of working than plaster model? In the next steps during our work, we can mill some parts and then check it. This way of working is already norm and precision has already been tested and proven. But what about printing process? Is this because about printer or resin or cleaning solution and lamp, or maybe how we treat this model, how long after printing we are using them? Are our models stable during time? What printer choose? What resin? How to clean? Wash machine, ultrasonic, alcoholic, special solution? Where and how long keep our models? So it is a lot of questions and we need to check it. To check it, we choose our master model, let's say mother model, made in plaster in gifts for class. Model are articulated in gamma reference. Occlusion was checked on color for 8 microns thickness. Then we scan this model in table scanner, which is more precise than intraoral scanner, and sent to different printing center and laboratory to prepare for us 2 pairs of models, and we also printed in our lab. So we received 12 pairs of models from the same scan, made in 6 types of resin on 6 printers. And we keep on doing this study all time. So now we have more resin and printer in this study. Then we make cross-mounting all of this model to our mother models. Fish checking show us that not every model suits perfect to bite register, which was made in hard material, not squishy. All printed models were rescanned and compared with original scan. After scan, we notice more differences. But why? They are all printed from the same STL file. As you can see on the pictures, blue is printed model and white is the plaster master model. Then we check occlusion of all these pairs. We notice a lot of differences. Remember that we would like to achieve precision at the level of 8 microns. In each pair, we notice contact points in occlusion in different places. Some are more close to our master model, so some completely different. Then 6 pair of this model was hidden in the dark box, and another 6 pair from the same resin left in the transparent box on the table in the laboratory. Then we repeat all the process of scanning and comparing all of models from dark and from light storage every week during 8 weeks. 8 weeks, we take that the normal way of time of preparing cases. We notice differences start to be bigger and bigger during time. So on the end, we compare 146 scans together with our previous master model scan. And what we want to check? Precision of printed models compared to the original scan, quality and precision of occlusal contact points, and stability of models during time. After comparing all of these 146 scans, we notice that every model starts changing after 5-7 days. To check how big difference is, we measure reference points on each scans. So it gives us 548 measurements, and here is outcome. We see difference between storage in light and in dark. The biggest difference was we have on posterior region, so that means that our model starts to not exactly shrinking, but changing the diameter, and posterior part starts to be wider. And no one models are stable, no matter in which resin is made. Of course, one resin is more precise, other less, but we observe that keeping in dark helps a little bit and slowing down the process of changing. But every resin starts to changing after 5 to 7 days. When we combine separate upper and lower, we see big difference. But when we check in occlusion, the difference is even bigger. So where we have our 8 microns, how can we check something? How can we produce something like silicon index validator to keep vertical dimension during preparation, or for tooth preparation index on this model? It's not will be stable in patient's mouth, especially for our VieSID concept, which is very precise. So conclusion, keeping the model in the dark slows down the changing process, but we should work on the printed models no longer than 5 to 7 days. After this time, we should repeat printing, so that means the precision, we should also repeat rescanning to checking this precision. The precision of the model depends on the resin, printer, calibration printer with the resin, type of washing solution and curing. We should check each printed model by rescanning and comparing with previous scan. We should check in occlusion before we make silicon index, and if it is necessary, make adjustment to not send to patient's mouth not precise silicon index. So I don't want to say that digital workflow didn't work in our VieSID concepts. I just want you to make you aware that we have to be very careful with printing parts to maintain high precision. Digital workflow will not be a faster and cheaper way of working, but digital workflow open borders. We can work this on the scans sent from around the world and condylographic data with doctors, no matter where they live, which is a big help because there are not many technicians working with this concept. We just have to be careful and always leave room to control the next stages of our work. And just like the professor said, always check, check, check, because it's Slavicek concept. So thank you very much for attention. If you have any questions, so feel free to contact with me. So thank you so much.
Microphone. Thank you very much for a magnificent presentation, Joanna. I would like to ask Cinzia to come up to the stage and to take the recognition. And we hope you handed it to the Joanna. If you, thank you. Alkışlarınızı xahiş edirəm. Şəfa xanım, otur. Just a second.
Əziz həmkarlar, yenə elan verim sizə ki, konferansımız davam edir, hələ 2 çıxışımız var. Ondan sonra bizim şirkətlərin təqdim etdiyi lotereya oyunu oynanılacaq və bütün həmkarlardan həmçinin möhtəşəm bir bədii hissəmiz olacaq. Xahiş edirəm, davam edək konferansımıza, coffee break'dən sonra.
Bircə dəqiqə bizim sertifikatımızı speaker üçün çatdırmaq lazımdır istəyirlər. One more second, maybe minutes. No, just 1 minute. They will be here and then. Wow, here they are. Joanna, can you see us? Can you hear? Thank you very much again, and this is recognition, a capit for your presentation, and thank you for everything. And we hope that Cinzia handed it to you
Thank
in
you so much.
Vienna or somewhere else.
Maybe I keep it?
Oh, we can say no.
Joanna, maybe I keep it?
We can share it.
Thank you very
so
much.
much.
Thank you.
Thank you.
Thank you.
Thank you so much,
Bye.
Joanna. Thanks, well done.
Thank you. Bye.